Great. So yeah, as mentioned, this is our second Turing-Roche Knowledge Share event. The aim of these events is to showcase the research the partnership is producing and to bring together members of the Turing and Roche networks and beyond to network, hear different perspectives, and ultimately build new connections. We're starting off with a monthly event and we'll be experimenting with the format over the next few events. If you're interested in getting involved at all, then please connect with us on the Slack. And I'm just going to share some quick slides to give an overview of the partnership before we get started. So hopefully you can all see that there. So yeah, what is the Turing-Roche Partnership? The clue is in the name. It's a partnership between these two organizations. I'm sure most of you will be familiar with at least one of them, but this slide gives a quick overview of both. We initially collaborated as two organizations through a data study group, which is a Turing-style hackathon, and then we embarked on a 12-week research project before formally launching our 5-year partnership in June 2021. This is our partnership North Star, which is kind of our guiding light over the 5 years. So enabling the generation of insights to better understand patient and disease heterogeneity and its relevance to clinical outcomes at an unprecedented level of precision in order to improve clinical care. And as you can see, there's a lot of different research areas and activities we hope to explore kind of over the 5 years to guide us to this. And what's not reflected in this as well is the connections and the collaborations we want to build as part of this partnership. So it's really critical for us to run events like this to get the kind of community involved. And one of the research themes we're looking to explore next as a partnership is predictive modeling. We're currently scoping this area as a partnership, and we have a senior postdoc starting in June to help us with this. So we're really excited to hear from our speakers today on this kind of really relevant topic for the partnership. So I'm really excited that we've got 4 speakers, 2 from Turing and 2 from Roche, giving lightning talks on different aspects of predictive modeling in healthcare. So I'm delighted to welcome Dr. Jasmina Bogojeska, Dr. Matthew Sperrin, Dr. Elif Ozkirimli, and Dr. Brieuc Lehmann. And yeah, as mentioned, we'll be hearing from all 4, and then we should have plenty of time for questions at the end. So a reminder, please feel free to ask specific questions to each speaker, or you can ask a question kind of for the whole panel to answer as well. And that is it from me. I'm now going to hand us over to Jasmina, who's going to get us started. Great, that looks good, Jasmina.
Okay. Hi, everyone. I'm Jasmina. I hope you see my slides. It's a pleasure to be here and kind of have the opportunity to present what I find a very exciting project called Navify Kidney Companion. And in this very brief talk, I will give you first the context of the whole project, and then a bit of more details on the predictive modeling part, which is the kind of the topic of this meeting. So this project focuses on chronic kidney disease, like improving patient care for chronic kidney disease, which is a growing global health challenge that places major burden on patients because it really severely affects their life quality and also healthcare systems. So there is about between 8 and 16% prevalence globally. And what is chronic kidney disease? Actually, it's a disease where the kidneys slowly lose their function, waste builds up in the body, and it remains for a long time asymptomatic, such that 90% of the patients actually are diagnosed quite late, because when symptoms like fatigue, frequent urination, nausea, and other headaches and other things kick in, then most of the patients are in later stages of the disease, where interventions are fewer and less effective, and also many, a large percent of late-stage disease can lead to dialysis, which actually has a very big burden both on patients and on healthcare systems. And there are many unmet medical needs, and in this project, we actually, the goal or the vision of this project is actually to improve patient care and to develop a system that early detects, like early diagnosis and early detects the CKD patients that are at high risk of developing this end-stage renal disease where their kidney function kind of, the kidneys basically don't function anymore, and such that doctors would, or clinical practitioners can actually prioritize those patients and spend more time with them and actually provide them with interventions that can, in early stages, even lead to delay, like a large delay, long delay of dialysis, and also even no dialysis at all. And also in later stages to provide like treatment, more aggressive treatment, such that dialysis is also delayed for a significant amount of time. And this is a big challenge, like identifying these fast progressors, these CKD patients across all disease stages that progress fast to end-stage disease. This is a very challenging problem, both for clinicians and for algorithms. So what we want in this project, the goal is to provide like a system where which kind of is a home for all different data that are relevant for the care of patients with this disease. And also an advanced algorithm that is trained on real-world data set and that can identify these fast progressors across all disease stages. And this will enable better care for these progressors and also interventions that would lead to delaying and preventing all the disease side effects and also the expensive dialysis. So how does the solution look like? This is really the algorithm we are working on. We call it RISC-AD. This is, we've developed a powerful nonlinear machine learning method that uses a large amount of real-world data set. These are electronic health records, like hundreds of thousands of, that come from hundreds of thousands of patients. And the algorithm is able to identify the fast progressing CKD patients across all disease stages, 1 to 5, and then also simultaneously for many different time horizons that are relevant for the clinical practice. And it uses normal like measurements that are available and that most doctors take and that are available in these electronic health records. And as you see here, it also, we provide outputs with a single model at different time horizons, starting from 6 months up to 10 years every 6 months with one single model. And we have quite good predictive accuracy. This is, of course, results from ongoing evaluation. We are still working on this. This is still unpublished work, but you see that for early stages, that the AUC is around 0.89, and for later stages patients, this is around 0.96. So what is this is, as I said, ongoing work. We are working on detailed evaluation of various aspects that are important for the practical application of this tool or of this algorithm. So different stages, missing data that are not available, like missing inputs that are not available, and so on. We want to also assess the impact in practice, like in different hospitals, and check what is the impact on the kidney, on the CKD patient care, how it improves kind of to quantify the improvements in practice. We are also working on a publication, so we want to publish the details. I just gave a very high level overview, but we want to publish the details of the algorithm and all the different evaluations that we are currently working on. And last but not least, I wanted to mention, we are a very big team, but I wanted to mention the data science team that works on this predictive algorithm, that focuses on the predictive algorithm development, evaluation, and so on. And this is Nicola, Christian, Martin, and myself. And of course, we are looking forward to, work together with other interested people, because it's a very challenging and interesting problem. And, being able to improve the patient care and even like remove dialysis completely from the care of CKD patients, that would be really, really a great achievement. And it was really great to be here. It is really great to be here. And thanks again for the invitation.
Thank you so much, Jasmina. That was great. And next up, we have Matthew Sperrin.
Hi, everyone. Thanks very much for the invite. Great to see so many people here. This is my first time at one of these events, and I'm already really excited. Such great attendance and great speakers. I'm just sharing my screen now. So my talk's a little bit different from Jasmina's. I'm going to focus on a sort of methodological question, but without going into too much methodological detail in 8 minutes. So I'm going to talk about the role of, or the potential role of causal inference in predictive modelling. So I'll start off with just a reminder, I guess, of what these prediction models are and what they're for. So, so we have some predictors, some things that we can measure now. We have some model in the beginning, which is maybe a fancy machine learning model like Jasmina was talking about, or even a simple statistical model like a logistic regression. And the idea is that we're trying to predict some outcome. So it might be a diagnostic model, and we're trying to predict whether somebody has a disease at present, or a prognostic model where we're trying to predict future development of a disease like end-stage renal disease. So I guess it's very common in the literature that people are building these models now, and and we can report the performance of those models. But I think the question is, what are these predictions for? And this is a non-exhaustive list of what these predictions could be for. So making decisions about interventions, which I put in bold. We'll talk about that some more. So we want to know whether to intervene on an individual patient in some way or not to. These models can also be used for audit. So, for example, looking at risk of mortality after cardiac surgery can be used to audit a unit performing cardiac surgery by comparing observed and expected outcomes. Or for counselling, so where these risks are sort of immutable, then it might be just a case of estimating for a terminal patient how long they have to live, so that they can put their affairs in order and come to terms with that, or also patient selection in randomized controlled trials, for example. So I'll focus mostly on the first one here, making decisions about interventions, which is quite commonly done with clinical prediction models. And the way it's often done is based on what is often called the risk approach. So if you're at high risk of something bad happening, then we should do something about it. So the example I'm going to use here is cardiovascular primary prevention. So cardiovascular disease, we can calculate somebody's risk of having a stroke or heart attack in the next 5 years, 10 years. And for anyone in whom that risk is high, we might consider prescribing a statin or another, like a blood pressure lowering medication, for example. And that's based on this graph from a very old paper, and essentially the idea comes from this very old paper in BMJ from the 90s, where we say that, well, if we prescribe a statin, there's some harm from prescribing that statin, which we can probably assume is independent of cardiovascular risk, although that in itself is a strong assumption. And once cardiovascular risk is high enough, the benefit of trying to prevent it is going to outweigh the potential harm caused by that intervention. And for harm, you could also read that as economic cost, inconvenience, etc. So this is based on the idea that this kind of chart is based on the idea that the reduction in risk of adverse outcomes is often constant on a relative scale, or at least that's a common assumption that we make when we're conducting randomized controlled trials. But we can actually go a bit further than this if we start thinking about using causal inference directly into our prediction models. So at the moment, we have these ideas quite separately. So we have our relative risk reduction that we estimate using a randomized controlled trial. In other words, we get a causal estimate of that, and then we separately estimate these absolute risks for patients. And if there's some sort of qualitative combination of those things. But we can actually be a bit more precise in our clinical prediction models by using causal inference. And that allows us to ask what if questions of this kind. So as well as what if I started taking statins, somebody interested in their cardiovascular risk could ask these various questions on the slide, like what if I stopped smoking? This can be integrated with a causal inference approach. There's two very basic approaches to do that. So the first approach that you might think of is called what you might call the plug-in or conditional approach. And this is where you essentially change the inputs to the risk model. So if you want to know what happens if you stop smoking, then change smoking status from current smoker to ex-smoker, and then compare those risks. Now, that's a really bad idea, as any epidemiologist or statistician can tell you, because those inputs, do not have any sort of causal interpretation. They're not contrasts that can be used in that way. A slightly better way of doing this that builds on this idea of combining a trial estimate with absolute risk is to say, okay, well, if I want to estimate the statin reduction, then we know that statins roughly reduce risk of cardiovascular outcomes by 25%. So if you're at 10% risk of cardiovascular disease, then a relative reduction of 25% would reduce that to 7.5%. So we can make those sorts of calculations. And there's various online tools that do this sort of thing, like this tool that I'm showing here that does this for SCORE2, which is another cardiovascular primary prevention risk model. But again, there is the possibility of going even further again, which is to explicitly use causal inference throughout. And and this is an area of active research at the moment, both in my group and a number of other groups. So if we think about causal inference from the beginning, so not trying to separately build a prediction model, but embed the idea of causal inference throughout, then that allows us to explicitly say at all points what the risk is that we're actually calculating. So it's not this sort of fluffy idea of this is your cardiovascular risk. We can say precisely, this is the cardiovascular risk if we do nothing. This is the cardiovascular risk if a patient takes statins. This is the cardiovascular risk if there's combinations happen, like takes statins and loses weight. And the last bullet is interesting, that's a slightly more complex question. So, what if you don't take statins now, but you keep an eye on your cardiovascular risk, and if it goes above 10%, then we start taking statins. So causal inference would allow us to have these more sort of complex intervention policies like this. So the the sort of machinery in the causal inference field for answering these kind of questions is there, and the way that we build prediction models, I think, is quite well defined. I think there is still some challenges perhaps in putting those together. I just wanted to briefly show why. So a sort of naive assumption that's often made is that when we calculate a risk like cardiovascular risk, or the risk we calculate first is the risk if nothing is done. And unfortunately, that's not true. So any risk that we calculate is always sort of relative to what happened to a similar population or similar patients in whom we're calculating the risk in the development data. So what if we made similar kinds of interventions to what we did for patients like this in the past? And that's what I was referring to before with regard to what does this risk actually mean? So it means this, arguably, for some applications, this slightly loosely defined thing of, what if we do something similar to what we did before? And just to illustrate the complexity there, there is a problem of treatment drop-in. So if we're interested in 10-year cardiovascular risk, then we might say, well, let's just take everybody who at baseline for our development data isn't on statins. But the problem then is that some of them will take statins during follow-up before cardiovascular risks, before their cardiovascular event. And of course, the ones taking statins, that's not happening at random with regard to their risk factor progression. I don't know how long I've got left, but this is my last.
You've got
slide.
about 30 seconds, Matt. So that's
perfect. So that, you know, I think there's lots of other interesting applications of causal inference in prediction as well. So one of those is in considering fairness of clinical prediction models, which is quite a complex question for clinical prediction. But we can use you know, ideas of like counterfactual fairness, comparing two people with different ethnicities, you know, what would their different predictions be, and therefore the different decisions that might be made. We can look at generalizability and transportability based on the idea that causal pathways are more likely to be preserved from one setting to another than, you know, more idiosyncratic associations that might be driving the predictions. And finally, dealing with feedback loops. So like if you deploy a prediction model into practice and then that affects people's behavior, so they start trying to prevent these bad outcomes that they're predicting. You know, then if you try and update the model based on that prediction, you get into all sorts of trouble, which again, causal inference is a way out of that. So that's all I had to say. I was just sort of setting out the stall for using causal, you know, the potential benefits of causal inference in predictive modelling. Thanks.
perfect. Thank you so much, Matt. And we have Elif up next.
Hey, thank you very much, Vicky. Hi, everybody. Let me share my screen. So I think it's quite interesting, without speaking beforehand, that I will also be talking about cardiac safety and cardiac adverse events. So this wasn't planned, but I'm pleased to hear about the causal inference and how it can be applied to cardiac adverse event prediction, or cardiac event prediction, let's say. And today, in this talk, I'll talk about cardiac adverse event prediction with healthcare claims data. I think I need to do a slideshow.
Yeah, I was going to say, yeah, that's perfect. Great.
Great. Okay. Thanks very much, everybody. Thank you to the organizers for sure for inviting me. It's a pleasure to be here at the second Turing-Roche Knowledge Share series. And I'll try to give a lightning talk, trying to whiz through some of our recent work, which is not published yet. So it's not even hot off the press. Our team includes Ken Wang, Alexander Skates, and Jonas Denk, all of us from Roche. And we have been looking at cardiac adverse event prediction using healthcare claims data. So how do we characterize drug safety in practice? It's usually done through spontaneous reporting. For example, FAERS, user vigilance, yellow card, etc. But these are designed for signal detection rather than for safety profiling. With real-world data, it's possible to design studies that allow us to better understand the profile of drugs, of the safety profile of drugs, and we can ask more complicated questions. For example, what is the effect of multiple concomitant exposures? What are the interactions in patient subgroups? What is the presence of risk-associated comorbidities, co-medications? And for sure, real-world data, hopefully, is a representative of a wider population where for a longer time period, rather than the signal detection. And here we focus on two such healthcare claims databases, MarketScan and Pharmetrics Plus, but for sure, there are other healthcare claims databases. Okay, so the objective of this work is to evaluate cardiac safety based on claims data. And here our challenge is to understand the safety profile of different drugs as it relates to this adverse event called torsade de points. And this is actually contributed to a significant number of drug withdrawals due to drug-induced ventricular arrhythmia. And we have two questions. We try to ask two questions using healthcare claims data. Can we use claims data to derive a quantitative measure and a ranking of cardiac risk for a range of medications? And for this specific case study, we focused on antipsychotics. And the second question that we wanted to ask was, can we use claims data for individualized cardiac risk prediction? Similar to the previous talk, perhaps. And for the first question, the approach that we used was a self-controlled case series, which is a pharmacoepidemiological study design that is using self against self, basically, as a to understand the cardiac risk of different drugs. And for the second question, we used machine learning or deep learning and these transformer models. To give a brief description of what the data looks like, in the healthcare claims data set, there are patient identifiers. For sure, everything is anonymized, you can imagine. Then the medical codes, here we use ICD codes, prescriptions, and patient demographics are included. This is what the data set looks like. And from the data set, we try to understand these two adverse event cases, cardiac arrhythmia and then ventricular tachycardia, where TDP is one form. So the question that we asked as a case study, what is the relative risk ranking for co-medication of antipsychotics? As I mentioned to you, we can ask these a little bit more complicated questions, such as co-medication, as opposed to, for example, clinical trials or spontaneous reports from these real-world data sets. And the real-world data set that we have access to has more than 200 million patients, but we start with this, you remember I mentioned to you about the ICD-10 coding and also the adverse event that happens. So we wanted to make sure that we had at least one compound of interest between the time period and also the event during that time period. So we were left with a relatively smaller cohort that has exposure to these pairs of compounds of antipsychotics. And our threshold for it was 10 aggregate total patient years of exposure. So in the self-controlled case series design, if you take a look at this patient history, the patient has, let's say, 3 adverse events, and they have 2 exposure periods. And the self-controlled case series is a design in which each individual is their own control. So in this way, you can explicitly control for time invariant confounders such as gender, ethnicity, or even social determinants of health, which may or may not be time invariant. But we do need to correct for time varying confounders such as age or comorbidities. And you see here comorbidity, this green comorbidity starts happening after this third segment. And the age, of course, as time progresses, age of the patients increases. And only the patients who experience adverse events and exposure contribute towards the model. And the question was, what is the relative risk ranking for co-medication of antipsychotics? And this, we used this relative incidence rate ratio that we calculated comparing these pairs of co-medications, where in this simple, let's say, formula, for any given drug A and any given drug B, the relative incidence rate ratio defines the effect size comparison of A and B. But remember, we were looking at co-medications. And then once we have this relative incidence rate ratio, we do a network analysis or a meta-analysis where you may be familiar with this meta-analytic approach, where the idea is to compare 2 different or more randomized control trials, which weren't designed to answer this ranking question, right? And we use a network meta-analytic approach to compare relative incidence rate ratio. And this ranking, basically, I won't go through the results, shows that the interaction effects show that the effect is not always equal to parts. There's a synergistic effect as expected. And this is also observed in the real-world data analysis. So let me switch gears very quickly and talk to you a little bit about how we use machine learning for personalized risk prediction, again, using healthcare claims data sets. So starting with the medical claims data, using machine learning to make a personalized prediction for risk of cardiac adverse events. Again, the same patient journey in the healthcare claims data set. And we start with this, the healthcare claims, we do a pathway modeling. And if you're familiar with this machine learning, deep learning approach called transformers, which is looking at temporal relationships between sentences, this comes from the NLP, natural language processing field, where the document is actually the patient journey. The sentence is each visit, and the words are the events that are recorded. And
Elif, you've got about 30 seconds left.
perfect. And we use this approach to make a personalized risk prediction for cardiac adverse event prediction. And this is what our architecture looks like. It's very similar to some of the approaches that are that you see related to, for example, BERT or other architectures. This is the transformer architecture. And the outlook is the following. So there are mechanistic models that basically take into account the patient as an average patient. And the machine learning model that models that use this real-world data sets or larger multimodal data sets can make some personalized, can help us make some personalized predictions about how the patient is going to behave. So let me quickly jump to the last page. Yeah, here it is. I tried to, in this lightning talk, 8 minutes, I tried to give you a summary to show that modeling patient variability and heterogeneity is key in precision medicine. And here we use two approaches: self-controlled case series, which can correct for uncontrolled confounders associated with each patient. In fact, this was also what the previous talk was about, I guess. And then machine learning, deep learning models, that, tools that can model patient variability by incorporating this temporal relationship between covariates. These are the two approaches that we used. And dissection of drug-related effect from patient-specific risk factors is particularly important for the development of an AE prediction tool, for precision dosing, and for personalized healthcare. Thank you very much.
Thank you so much, Elif. That was great. And now, last but not least, we have Brieuc.
Thank you. I'll just share my screen. How's that?
Yeah, that looks great.
Lovely. Okay. So yeah, thank you for the invitation to speak at this this knowledge share. It's really great to be here to share some of the work that we've been doing at the Turing-RSS Health Data Lab. So that this is a lab set up to support the UK government's response to COVID in terms of statistical modelling and machine learning approaches. So I know that the topic of this knowledge share is predictive modelling in healthcare, and there isn't going to be an awful lot of prediction in this talk, but hopefully the ideas are certainly relevant and will hopefully be interesting. And while the title of this talk is a bit technical, the main kind of message or idea that I hope you can take home is the complementary nature of randomized studies and observational studies, and that by combining data from the two, we can kind of get the best of both worlds, and they can be kind of mutually beneficial. The example that I'll use to illustrate this idea is COVID testing data. And this is a quote by a famous epidemiologist. If we did half the testing, we would have half the cases. And some of you might know already who said this. And while you might not agree with everything that Donald Trump has to say, he's probably not wrong in this case. You know, the number of cases that we identify is highly dependent on the number of cases taken. And so you might say, well, sure, let's not look at the actual number of cases, but we could look at the proportion of tests that return positive, so the test positivity rate. But the problem with this is that the people who are taking tests aren't necessarily representative of the wider population. And so we might have bias in our testing data. And so this is what we see in practice. So what you see here are prevalence, so how many people, what proportion of the population have COVID in a particular time point. So this is roughly December 2020, roughly January, February 2021. On the y-axis, you have the number of, the proportion of people who test positive who have taken a PCR test in the UK. On the x-axis, what you can see is the proportion of people who tested positive according to the REACT study. And so the REACT study was a randomized surveillance study where they sent out swabs to people at random across the UK. And this is essentially should be an unbiased measure of prevalence, more or less. So what you can see here, each dot corresponds to one of 300 local authorities in the UK, and you can see this upward bias of the PCR test positivity relative to the kind of unbiased randomized prevalence estimate. So the question is, can we debias this fine scale pillar 1 and 2 PCR data? So the reason that we get this bias in the pillar 1 and 2 testing is because of ascertainment bias. So essentially the people who are getting tested aren't necessarily representative of the wider population. So what you can see here is a causal directed acyclic graph, a DAG, which shows that the possible kind of relationships between the process of having coronavirus to begin with to testing positive, and this is the data that we actually collect. So if we were to ignore this path from infection to tested to result and assume that actually anyone was equally likely to get a test, whether or not they had coronavirus to begin with, then we could kind of assume that everything was unbiased. But the fact is that you're more likely to get tested if you have symptoms, and you're more likely to have symptoms if you have coronavirus to begin with, then this leads to this bias in our final estimates. So our task was, can we model this bias to estimate the fine scale local prevalence more accurately? Our two testing streams, as I mentioned, was the randomized surveillance data from REACT. I won't go into too much detail given the time. And then the pillar 1 and 2. So pillar 1 is just the people working in hospitals or in care homes, and pillar 2 is the ones that were this is when back in the day when people were getting PCR tests if they were displaying COVID symptoms. And just to speak very briefly on what I mean by the fine scale, England is split into these 9 Public Health England regions, which are then split into roughly 300 local authorities. And while we can use the REACT data to get estimates fairly accurate at the regional level, there isn't enough data at the local authority level to get kind of precise estimates of prevalence. And so we wanted to be able to get these more local-based prevalence estimates of prevalence, essentially to be able to guide policymaking at a local level. Very briefly, this is the model. So we're going to use the randomized REACT data, U of U, along with the biased targeted pillar 1 and 2 data. We're going to use this, fit this at a coarse PHE region level, to estimate this bias parameter that I mentioned previously. And then we're going to input essentially as a prior, if you're familiar with Bayesian statistics, we're going to use the output from this core scale parameter here to infer the local prevalence pi, now ignoring the randomized data. What you can see here is the output from our model essentially. So the top panel is what you saw on the third slide earlier. So the uncorrected pillar 1 and 2 prevalence estimates against the unbiased React level estimates. And on the bottom row here is the output from our model, which shows the corrected debiased prevalence estimates after fitting the model on the previous page. And there's two things to notice here. One is that we're doing a fairly good job at debiasing these prevalence estimates, as we can kind of see that all these dots corresponding to prevalences at the local level essentially lie pretty close to the x equals y line. The other thing you can notice is that the uncertainty intervals are a lot smaller for our uncorrected, so for our debiased prevalence estimates relative to the React prevalence estimates. So this is where you see the benefit from combining the two data sources together. We get much more precise estimates of prevalence relative to if we were just using the React prevalence only. So just very briefly, this is about prediction. So we can use these, in theory, use these prevalence estimates essentially to estimate the effective reproduction number RT, and then we can use these to predict changes in case numbers. And we do a reasonably good job, particularly when prevalence is high. So just to wrap up, few take-home messages. I think that accounting for ascertainment or sampling bias in data sets is crucial, and we've seen that kind of inference and prediction can suffer if you try and generalize results outside of the sample that you actually have. Randomized studies are extremely valuable. We're very lucky in the UK to have 2 randomized surveillance studies. React is no longer active, but the ONS community infection survey is still ongoing, and that allows us to kind of estimate these, to generate these unbiased estimates of prevalence. And finally, hopefully just illustrated in this particular example that combining randomized studies with observational studies can bring the best of both worlds. So, you know, randomized studies are like fairly expensive to run, especially if you want to do them at a large scale, whereas observational studies tend to be a little bit cheaper. And so by combining the two, we can kind of get the unbiased nature of the randomized studies with the kind of statistical power that comes from observational studies. I'm just going to flash these up, and this work was mostly in this Nature Microbiology paper. I'll post a link in the chat very shortly. This is another paper which kind of expands on some of these ideas that I've presented here. Thank you for listening, and I'll pass back over to Vicky.
Thank you so much, Brieuc, and thank you so much to all of our speakers. That was a great whistle-stop tour, and it was great to hear about lots of different work going on at Turing and Roche. I've put a link in the chat to the Slido app, so feel free to ask any questions there, whether to a kind of specific speaker or if you have a question that you'd like all of our speakers to answer. We've got just about 10 minutes for questions. So I think we've mainly got specific questions first. So Jasmina, maybe I will kick off with you. So one of the top questions was what features were kind of collected from the electronic health records? Was this longitudinal data, i.e. were the outcomes labeled? And how was fast progressor defined clinically and biochemically?
Okay, yes. So from the electronic health records, we collected stuff like lab values, like creatinine, albumin, and other like blood and urine values, along with some demographics like age and gender. Not too many other features. So many labs and some demographics, and then the end, like how the endpoint or the outcome was defined as like a patient being diagnosed with end stage renal disease, so kidney completely malfunction within a certain period, because we had these different periods where we predict the risk. So that's how we define kind of the outcome of the target, if you will, for the model. Yeah, what were the other questions?
About the fast progressor bit, did you cover that bit? You can post it in the chat.
Yeah, so for the fast progressor was this. So so if you say, okay, a fast progressor is someone that gets end stage disease within 4 years, then you see whether the patient got certain, like whether the patient got diagnosed with end stage disease within 4 years. So it depends on the time period how you defined it, and we provide many different time periods such that clinicians can choose, depending on the stage, which one is relevant for a certain patient. So that would be a fast progressor, for example.
Great, thank you so much. And next, a question for Matthew. What historical data was used for the causal models? Is it possible to report a confidence metric with the risk value?
Right, thanks. So yeah, in terms of the data, so I guess I was giving a general talk, so I'll give a general answer, which is that sort of similar to what Brieuc was talking about. What you ideally want to do here is sort of fuse data from, you know, say observational data from the setting where you're interested in deploying your prediction model. So that might be electronic health records that you believe represent the healthcare setting where you want your model. But then we know that it's extremely challenging to try and estimate causal effects from such data, although there are methods available. So combining clinical trial data or systematic reviews, meta-analyses of relevant clinical trials to get those data is the way to go. I think we're a bit behind where Brieuc's work was in terms of having, you know, a really explicit framework of how you should best combine those two sources of data to maximize the use of them, but there is sort of a lot of work in that direction of how that should be done. The second part of the question was about a confidence metric with the risk value. So I'm not exactly sure what the question means, so feel free to clarify exactly what you meant. But so there are, so in a standard prediction model, we can, you know, with the sort of standard techniques to look at discrimination and calibration of the models, like C statistics and looking at calibration plots of observed versus expected outcomes. And there are similar metrics available for essentially looking at the causal contrasts within those models as well that are being developed. I guess if the question is about confidence in the risk itself, then that's, I think, a slightly philosophical question, because you can certainly calculate a prediction interval for the probability of an event and report that. What such an interval means is, at least to me, a little bit less clear. But you know, you can do that, you know, just in a sort of standard way, at least with, you know, at least if you think about having a simple regression model that you're building your risk prediction model with.
Yeah, sorry, Matt, I might have thrown you a bit of a vague one there. If we have time, I've got a more specific one for you as well. One for Elif. Does the self-controlled case series allow for control of variability in medication compliance?
This is a great question. Thank you very much. Actually, this is a challenge with any kind of real-world data, right? So the insurance claims is data set is following which prescription is which drug is prescribed, but it's not following compliance. So we don't know if the patient is really taking that drug or not. We don't know if the patient is taking the drug during the exposure period, or maybe maybe they stop after a while, maybe they just continue because they feel better, right? So we don't know. So this is one of the limitations of real world data. So for example, another limitation is at the end of the day, these are human beings recording these events sometimes. not for everything, especially in hospitalization. Most of the events are recorded at the hospital, but how in the clinic they are recorded actually plays a huge role in data collection. And here the hope is, because as we collect more and more data sets, your confidence interval or your confidence in your prediction is going to increase. But for sure, I'm really happy to hear these two talks related to causality. These causal relationships are actually going to inform some of these confounders and what you have to take into account when you examine anything, any data that you collect in the real world. Thanks for that question.
Thanks, Elif. Brieuc, for you, I guess, I know that paper was published quite recently, so I wondered if you kind of wanted to talk about next steps of the work or kind of how that's kind of being applied.
Yeah, so there's an interesting challenge whereby you can think of, well, there's two things. One is you can think of different randomized studies. So in the UK, like I mentioned, we have the ONS study and the REACT study, and they have slightly different study designs in terms of how the PCR tests are randomized within the country. And so it would be interesting to compare the results from each and try and understand if there are differences, why they arise. A similar thing would come from the kind of the different testing streams that I mentioned. So we combined pillar 1 and 2, the PCR tests into kind of one testing stream. You can think of splitting that into pillar 1 versus pillar 2, and also trying to bring in the lateral flows results in there as well, and to try and understand how the prevalence estimates are affected by using the different streams, and also if they are affected by, if there are differences between the different testing streams, how do you go about combining those data sources in a kind of principled way, and what's the thinking about what the right way to combine those is. So that's kind of the kind of things that we're thinking about at the moment.
Yeah, that makes sense. That's great. Thank you. This is probably our final question, depending on timing. It's for Jasmina, but I actually wonder if all the panelists kind of want to comment on it after she has. So Jasmina, the question was kind of how racial differences were accounted for in assessing the presence or the kind of degree of kind of renal failure. So kind of adjusting for higher serum creatine in Black patients. But I wonder, once you've answered, I know kind of Brieuc has an interest in kind of data diversity and things like that. So I wonder if everyone would like to comment after Jasmina.
Yeah. So we don't do any adjustments. I mean, we designed the model such that it works on the real world data, and we hope that the data, I mean, our model is trained on like 500,000 of patients, will learn this thing, all these different facets of the disease automatically. So we don't explicitly account for any things. We just hope that the large amount of data will cover all the different cases.
Great, thank you. Any other comments from the other panelists?
Well, I could probably talk for an hour on this, but briefly, I guess what you have to watch for is that all an algorithm will do is learn from the data. So if the data is already biased, you'll just perpetuate those biases. So a well-known example in this sort of space is that if there's underreporting of the outcome in a particular ethnic group, then ethnicity might look protective for that outcome. And so I think one way around that is to sort of check that a protected characteristic isn't getting less access to health resources because of your prediction model. That seems to me to be quite an appealing, crude way to handle this issue.
Yeah.
Brieuc, I know you've just put the link in the chat as well.
Yeah, so this is something I'm very much interested in, and just echo Matthew's comments there. This isn't just a cheeky plug for Data Science for Health Equity, which is a community of interest around data science and health equity, trying to bring together kind of everyone who's working at that intersection in terms of researchers, like clinicians, policymakers, funders. So if you do have an interest, do check out the website. And thanks for the opportunity for the plug, Vicky.
Yeah, I promise I actually didn't, it was a legit question. I didn't plug that one in. But yeah, thank you. Elif, I don't know if you want to add any comments, but no worries if not, it's so close to time.
I mean, I agree 100%. The data collection is going to inform actually how we collect the data, and the data collectors or the data producers need to have these data cards basically to explain what kind of data, what kind of cohort is part of that data set. I mean, there are underrepresented, undermet communities for sure that are not part of that sampling space, that are commonly left out. And at the same time, there are these overrepresented communities from which these machine learning models are learning, right? Or memorizing almost. So very valid points. And thanks, Brieuc, for sharing the data science for health equity link.
Perfect. Thank you all so much. Yeah, it was really, really great to hear that. And thank you so much to our speakers. I really enjoyed the talks today, and I hope you all did too. As mentioned, we've recorded the event and we'll be uploading that to our Turing-Roche YouTube channel, and we'll be sending the link round to all the registrants, and we will be sharing the slides as well. In the meantime, thank you all for attending and those who asked questions. I will pose any leftover questions to our speakers in the Slack channel. And feel free to log on to that, start any conversations about what you heard today. And as mentioned, it's really a kind of a space for you to kind of, yeah, share any events, opportunities, and get chatting really, so we can build these connections between the community. Our next event will be on synthetic data. We're still setting a date for that, so look out for that. And yeah, I think that's everything from me. So thank you all so much, everyone, and hopefully see you soon.
Thank you.
Thanks. Bye-bye.
Everyone.